Hello, my name is Cosmina Dusan. We have Dr. Silvia Chedid from Brazil. Welcome everybody to our live with Dr. Chedid. Thank you so much, Dr. Chedid, for being with us from Brazil. It's 6 p.m. At your country. Um, and I would like to start to invite you to say a few words about you so we know each other and everybody who's watching us will know about you. What are you doing? I know a few things because we are in contact since the pandemic time, and I really wanted to know you in person because it was absolutely amazing what I saw that you are doing in your office. And I want everybody who is here with us to know what are you doing, what amazing things are you doing in Brazil, and what amazing things you will teach us when you will come to Timisoara in 24 October to our master class with you, Preventing Malocclusion on Babies. Please, Dr. Chedid, you have, you can tell us all about you.
Thank you, Cosmina. It's really a pleasure to be here with you. For us here in Brazil, it's midday, 12 a.m. It's really a pleasure to share a little bit about my work, a little bit about myself, and I hope you get inspired and motivated to be with us in our Congress in October. See? Well, I first started, like I think most of you, interested in caries, interested in solve this problem. And I started studying sweeteners because we all know that the sugar is the greatest villain concerning caries. So I was in my researchers searching alternatives to the use of sugar. So I started studying sweeteners like stevioxide, which is regularly found naturally found here in Brazil. Xylitol, that at the ages, the 18th years, it was appearing in the market. So xylitol, aspartame, and other sweeteners. And I started studying these sweeteners as an alternative to the use of sugar. And as they are not metabolized by the bacteria, I found an antichoriogenic effect, bacteriostatic effect on the sweeteners. But it is really very difficult to quit the use of sugars or to substitute sugars for sweeteners. So I changed the line of my investigations and start studying fluorides, still at the fields of caries, prevention of caries. And I developed, I think the most important studies I did concerning fluorides is to define the small amount of toothpaste to be used by babies. So how much would be the smallest amount of toothpaste with fluoride, secure for babies and at the same time able to prevent caries. And that's why, according to this work we made in deciduous teeth, because at that time we only studied permanent teeth, not deciduous teeth. So it was probably one of the first studies that evaluated the influence of a small amount of toothpaste to milk teeth. And we have a table. That's why now we say we have to use half rice grain or a grain or a rice grain. We because of these studies, we suggested this sort of association. And Cosmina, what happened is that at that time, I couldn't find any more decays in my practice, my clinical practice, because it's really simple in a way. Just brush teeth with fluoridated toothpaste and control the consumption of sugars. So I didn't see caries anymore, but I started to see a lot of malocclusion. And as a pediatric dentist, I am a pediatric dentist, I didn't know what to do because the mother was concerned about the malocclusion and asked me to do something. And for babies with months, with 1 year and a half, I really didn't know what to do. So I thought myself, I have to do a specialization in orthodontist. I have to do a specialization in orthopedics. And I went to do these specialization courses. And still, I didn't find the knowledge I was looking for. And at that point, I thought, well, I have already done my contribution in caries. I think I have to change the direction of research once again. And as I cannot find a solution to the problems I'm facing, I will start to, I get the knowledge of pediatric dentistry, orthodontics, the orthopedics, and I will adopt it for the babies. And then I wrote the first book. The first book was Orthopedics and Orthodontics for Deciduous Dentition. And it was one of the first books concerning this theme, how to manage malocclusion in the deciduous dentition. And I thought, well, if it's not approved for the researchers, the important researchers in Brazil, no problem. I have already done my contribution, and this is what I would like to propose. And surprisingly, it was a big success. And I started, more and more investigations about this. And nowadays, Cosmina, I'm convinced that if we want to prevent malocclusion, it's not at the moment the occlusion, the deciduous occlusion is already established. It's before. And if prevention, the real prevention, have to start before, we have to start monitoring since pregnancy. And of course, I have a lot of inspiration with my patients because they search for solution. They came to me asking to do something to prevent malocclusion. And interestingly, I had a patient, a special one. I will talk about this case in the seminar in October, which has about 3 months when she came to me, and she had a very hypotonic position of the tongue, flaccid tongue, and a very dysfunctional way to swallow. And at that time, with 3 months, this girl has nowadays 18 years old. So 18 years ago, of course, I didn't know what to do with this baby. And we tried everything. The mother had depression after labor and couldn't breastfeed. And of course, it's always about breastfeeding, isn't it true? And the mother felt so guilty because she couldn't breastfeed her baby. And one time when she always came to the appointment asking me what to do, or with hope that we could find something to help her baby. And in one of these appointments, she said to me, Dr. Silvia, it cannot be my fault. It cannot be because I couldn't breastfeed. My daughter, my baby girl, has this sort of swallowing since she was in my belly. And I said, really? How do you know about this? Because I had the images. And then she brought to me the images of the ultrasound, and it was there. the way she positioned the tongue, the way she's swallowing was exactly the same way she swallowed after birth. And then it inspired me not only to take care of babies the way I have now a protocol, and I have now much more knowledge and doing researches about this. Then, because of this baby, I started to monitor not only ultrasounds, but the baby as soon as he's born, and monitor up to the time the deciduous dentition is established. And this is real prevention, and this is what we are going to talk about seminar and today and whatever.
Oh, perfect. It's so amazing. I could stay and listen until tomorrow. And I really can wait to hear all about that in 24 October. And it's very, very important that these malocclusions are discovered earlier. And it's interesting now how the ultrasound images can help us to know what to do after the child is born, soon, very soon after the child is born, not to wait until the child has the teeth. So it's important to know what to watch when a child comes into
Yes.
your office, especially the children so smaller are coming in my office for frenectomy, right? Tongue tied, they cannot breastfeed, so they cannot be breastfed because of the tongue tie, and that's the first priority. Why are they coming in our offices at such an early age? And I really I'm able to recognize that I'm not watching at the tongue, I'm not watching at the gingiva. I always said myself, it's time to do that after the teeth are coming, because this is in our books when we are learning in school, and this is something new. And I think every doctor who will know these things, they will have a plus. They will be more able to see a child and to know what to do when the child will come for the tongue tie. And the doctor will say we will have to do more work with this child if we want to have a good teeth or development, facial growth, very harmonious, and all the things. It's I think it will be not only amazing, but it will be also for the parents something new. They will have to have some time of adjustment, because no one, I think here in Romania, until now, can say that they are doing these things, preventing malocclusion to the babies on such an early age.
Yes, yes. You mentioned tongue tie, and I think this problem because of this problem, because ankyloglossia, babies are coming to our office. But Cosmina, I have to say that ankyloglossia is the minimum problem that we can observe or find in the babies. It's about 10% of the problems. We have a lot of things to observe, of course, problematic ones and normal ones. But the main thing is not only observe intraoral but extraoral. The baby's a system. It's not only a mouth, only a tongue tie, only a tongue. And unfortunately, we still, as a dentist, have a narrow mind, narrow observation, and now we are focusing only in the tongue, only in the tongue tie. I'm inviting you all to broaden your mind, broaden your vision, to observe the babies as a system. And that's why the transdisciplinary team is so important. You see, I got the fortune in my graduation course and afterwards in my clinical practice to be involved with hospital and hospitals teams. And I had the opportunity to be at neonatal uses, observing the premature babies, and not only these babies, but the handicapped babies as well. And how the speech therapist, the physiotherapist manage these babies and these children, and how the system can influence the oral, the mouth, the oral care, and how the oral care influence the rest. So the beauty of the transdisciplinarity is that I learn with them. I, adopt the knowledge I receive to our fields of actuation, and the same occurs with them. So we exchange information, and in the transdisciplinary way of work, the knowledge is horizontal. It's not vertical. It doesn't come the physicians first, then dentist, then physiotherapist or whatever. Everybody has the same knowledge. And with the same knowledge, our diagnostic improved a lot, because I start to get the otorhinolaryngologist. My diagnostic for that is better now, because I have the otorhinolaryngologist knowledge. And the vice versa, the otorhinolaryngologist start to knowing about the oral health and start to make a better diagnosis. And we work together. And when I recommend to my patient an otorhinolaryngologist of our team, he will know what to do, because he's already concerned about the whole thing. It's different in the multidisciplinary team. You recommend the patient to another professional which is not concerned about the whole thing and the whole knowledge we have, and may observe the baby and say, there's nothing to do. It's okay. No, we don't need to do anything here. And then you cut the process, and you cannot, at the end of the day, promote oral health and health in a general form, you see. So it's really very important to work in a transdisciplinary team, because it's not only about tongue tie, it's not only about tongue, it's not only about the oral cavity, it's about the system. So it's really very important to be in a team. And besides that, we receive the knowledge of the other specialties, and we enlarge our form of actuation. And when you start looking not only inside the mouth, but in the face, in the cranium and everything, we start observing other alterations, other deformalities that can impact and influence symmetries and influence the development of the occlusion, the development of the baby. So the first step is to be inserted in a transdisciplinary team. And of course,
what do you mean transdisciplinary team? You said an otolaryngologist, a speech therapist. Speech therapist comes a little bit later.
No. I start, Cosmina, with the obstetrician. Okay. Or the gynecologist. So I start with them. We have a very, very, very close partnership, because we start in our practice since pregnancy. So we start with the obstetrician, gynecologist, then the neonatologist and pediatrician, okay? Then otorhinolaryngologist. Then when I'm talking about speech therapist, here in Brazil, we have a lot of specialties in speech therapist. And most of them are focused in therapy taping, or oromotricity, or breastfeeding, or techniques involved with the digital compression exercises, osteopathics as well, physiotherapist, specialized in osteopathic kids, osteopathic. We have the same work together because, we have sometimes alterations, asymmetries in the cranium, like plagiocephaly, like brachycephaly, and we manage the bone, the baby's bone, because it is already plastic.
Mm-hmm.
So when we observe in an extraoral observation risk of asymmetries, we work together as a transdisciplinary team. And when I say transdisciplinary team, means that we have all the same knowledges. Okay, it is different when you have specialties, different specialties, but each one in her own knowledge. You don't share the same knowledge. So the transdisciplinary team, everybody has the same knowledge. I am a little bit speech therapist, I am a little bit otorhinolaryngologist, I am a little bit, because it improves our way of diagnostic, because I amplified my vision of the situation of the baby, and I can recommend the treatment more secure, more efficiently. See, and as we have here in Brazil a lot of specialties in speech therapists, we can manage very precisely and make a better diagnostic when you have, for instance, a tongue tie problem, or if it's not a tongue tie problem, it's just an immature, the baby is not mature enough to swallow, to breathe, because during the intrauterus period of life, the amniotic liquid is being swallowed, is being breathing as a preparation for these functions at birth. And sometimes even a terminal baby, I mean a baby which is not premature, even this baby can be born without the maturity to these functions. And if we have specialized professionals, and if we are, capacitated to make this diagnostic, it's not a question of tongue tie. It's not a question of difficulties in breastfeeding because of an ankyloglossia. It's just because the baby is not mature enough. And then the knowledge we learn, we have concerning the manage of premature babies is the same we are going to use in babies which are not premature but have the same problem. Okay, so most of the techniques we use in our babies in the first 1,000 days of life to prevent malocclusion came from the knowledge of prematures, which are already established in the literature, and came from the handicapped babies, which still have the stimuli and the specialized treatment to improve function and to improve. Of course, we deal with function because the first treatment is always function. But if we as dentists observe alterations in the bones, asymmetries in the bones, a bad relationship between the gum pads, the gingivas, then of course it's our part of the work to, together with the transdisciplinary team, adjust with the functions to harmonize the bones and the relationship of the gum pads, preparing this proper relationship for the eruption of the deciduous dentition. And we will monitor this up to the end of the eruption of the second molar, when the deciduous dentition will be function and healthy, established. And then following monitoring this.
Perfect. So you are taking the child even since he was stillborn, and you are going with all this kind of treatment and follow up till the permanent dentition.
Yes, yes. Nowadays, Cosmina, I am changing a little bit my way of work because, I'm almost to retire because it's been 40 years now that I'm working. And I am, I'm now focusing only in the deciduous dentitions. What I mean is, I start since pregnancy, and then, of course, the duty of the orthodontics, I used to say, is to monitor up the eruption or extraction of the third molars, isn't it true? But nowadays, I'm not focusing on this anymore because, I am now almost to retire. So I monitor up to 5 years of age.
Mm-hmm.
And then, uh, you know, my experience now is that the baby is ready at this age. The skeletal part is corrected. This is the most important part. And then the baby is kept in the monitoring, sometimes with retainers, most of the time with retainers, but removable ones, because it's just a question of monitor and stimuli of development, because the problems with the pattern were already corrected. Retrusion or protrusion, transversal problems or vertical problems are already corrected at the age of 5. So, in general, I developed the orthodontist or the orthopedics, and then keep on working only with my babies and my children. Nowadays, this is what I'm focusing my work. But of course, the idea is to do the main job at this first period of time at 5 years, correct the skeletal problems, transversal, vertical, and anteroposterior problems, and then just prepare this space to eruption of the permanent teeth.
Perfect. So when you will come in 24 October, you will teach us also about Chedid's protocol, right? Of preventing of malocclusion in babies. You implemented it since 2013 in your practice. And this transdisciplinary team, I think each doctor has to make his own team to collaborate. I think the most important for me are the family doctors, the pediatric doctors, that they are seeing the child since they're born. And I think we have to go from office to office to these pediatric doctors, and to make them know that there are solutions for the children who have some developed problems of the face, of the bones, of the maxilla, problems inside the mouth that are about the occlusions, and they will know where to send these children. In Romania, for example, the pediatric doctor is the first one who sees the child, and keep the contact with the child until he's an adult. So I think we will have to start from that area.
Yes,
And I also work with otolaryngologists, with children who have amygdals, big amygdals, and they breathe on their mouth, not on their nose. I send them, the doctor do his job, and then comes to me to work with the child on myofunctional therapy to make the child breathe on nose. But it's some doctor that I know he's good, he's doing this kind of job. We are not knowing, even not knowing each other. I have to
yes,
go to meet him and say, it's me, I'm the one who's sending you the patients and you are sending me back. So I think the transdisciplinary team will be a challenge, because there are a lot of a lot of participants in this transdisciplinary team. I also heard about some appliances that you are using on babies. Why are you using these appliances, and when will this appliance is appropriate to be used? For what kind of problems?
Cosmina, I just want to complete your talk by saying that we have special criteria to interfere. Okay, we won't intervene in all babies. We have a special criteria, and of course, to start with the transdisciplinary team, I will show you some some techniques and some protocol we have to start with a very good transdisciplinary team. It's not only about exchanging cards and let's work together. It doesn't work like this. We have a special protocol to enlarge our transdisciplinary team. And of course, when we have skeletal problems, because it's really very important to make a good diagnostic. But if we start since pregnancy and monitor the baby in the first 1,000 days of life, even if we have, or even if we observe skeletal problems, genetical problems, observing the parents and observing, of course, the tendency of the relation of the gum pads, the gingiva in the babies, with simple exercises, because the bone is plastic, we can adjust, harmonize this growing. But sometimes, of course, the skeletal problem is stronger than the all simple interventions we do, because it's always very simple and always very it's not invasive. We respect a lot the mouth, the condition, the baby's condition and everything. But sometimes the skeletal problems is stronger than all efforts of doing what we do in our protocol. So we need to start with appliances. And most of the appliances we use are fixed in the mouth of the babies, because we are managing babies with 1 year and a half, and we start with the appliance when the first molar is erupted, not before that. I don't use appliances before that, because we have techniques and special exercises to be done, or to teach the parents to do when we monitor the exercises. And when the parents are committed with the treatment, in general, it's really very quick, the results with baby. And here is a very important thing. We have to know and have to learn and make a diagnosis of the family, because the baby cannot treat himself. He needs somebody, he needs an infrastructure at home. And we have to learn to make a good diagnostic, because if the parents are not committed, don't waste your time. Do not start doing anything. Our duty is to inform about the diagnostic we are doing, the possibilities to treat, because we have nowadays possibilities to treat, and the decision has to be in a transdisciplinary team, but the parents have to addict or not. And if we observe that the parents don't have an infrastructure, because sometimes they are apart, sometimes it's the grandpa, the grandma, which is taking care of the baby. I mean, if we don't have the structure to do whatever we need to do, it's better not to do, because we will fail and the duty will be ours. The parents will say, we started doing this, but it doesn't work. No, we didn't achieve the results, because they will not assume that they didn't do their part, of course. It's the same thing when we are talking about brushing teeth. It's the parents don't start the habit at home. The children keep on eating candies, we'll have candies. So the same thing, if the family is not addicted to the treatment, better not to start. And if they receive the information, if we receive the orientation, and in the future they have, the problem established and had to do the invasive treatment, the invasive orthodontic treatment, they will never say, if I had information and was at Dr. Silvia, she didn't say anything to me. Now look at this, look at what we are facing now. They won't say this because they received the information. But the decision to start or not to start has to be
The parents.
together with the parents.
So that transdisciplinary team implies also the parent.
Yes, yes.
First of all,
Of course, we need the transdisciplinary team because maybe I can say we have discrepancies in the bone in this area. But the speech therapist say, no, we cannot manage the tongue at this time. Maybe we need to wait a little bit more. Or the osteopathic or the otorhinolaryngologist. No, it's not the moment to make a surgery, or let's start with another way. So, of course, we need to decide in a transdisciplinary team, but the parents have to take part of the decision because they will be the ones who are taking care of the treatment at home. So they have to be addicted to the treatment. Otherwise, better not to start because it's not an emergency. Malocclusion is not an emergency. We can treat malocclusion with orthodontic treatment at any age, even right now. If I want to align my teeth, I can do this. The point is, it's more invasive treatment. It has the impacts in quality of life. Of course, at my age, to start an orthodontic treatment will impact a lot in my quality of life, in my social conditions. It's not a nice thing to do right now. And when we have skeletal problems, the protocols of orthodontic treatment are very invasive. Disjunction, we have to make a disjunction or extraoral mask, face. We have, rapid expansion of the maxilla. They are more invasive treatments and they impact more in the quality of life of the teenagers. The addiction to the treatment when you are a teenager or when you are older is more difficult. So at that time, they will say, if I listen to the Dr. Silvia, if we started before, at the age of 5, my daughter, my son would be ready just to use appliance at night, removable ones, and of course in a very comfortable way. See? So when we have skeletal problems, we start as soon as possible and then we use appliances with babies, fixed ones, and after the certain period of time when which is really quick treatment, because as I said, the baby's bone is plastic, so it's easy to harmonize. And if it's not quick, something is wrong. Make up your mind, make up your diagnostic once again, because if it's not quick, the response is not quick, something is wrong, something is not good. And then after this period of time with the fixed retainers, then we keep on using these retainers, but in a removable situation only at night. So it goes through a high frequency with low intense. This is the main idea of the protocol.
Great. Perfect. So there is a protocol. We will find out about him in 24 October. And how can dentists can be specialized in working with babies? We don't have this specialty in Romania. So I know you make a lot of courses, you make a lot of them also in English. You make them online, but also in Brazil. You are going all around the Latin America. And how can we found you, or how can we specialize in this kind of work?
It's a very interesting question, Cosmina. Let us talk a little bit about history. Well, ideally and protocolly, the babies were carried with the neonatologists or pediatricians. See, we didn't have dentistry for babies. But because of the bottle feeding with sugars and the caries in the babies, they started to erupt, and then already with the case here in Brazil, we have this very important problem. Then the neonatologists or the pediatricians didn't know what to do with these caries because they only know to pull teeth out, and we couldn't pull all the teeth, all the teeth with caries out of the babies. So the dentistry for babies start here in Brazil with Dr. Luiz Walter. He passed away nowadays. He's not with us anymore. But it started with this doctor, and we here in Brazil started to learn how to make an endodontic treatment in the milk teeth, how to make crowns. I think that Jorge Cassian will be with us in the seminar. He will talk brilliantly about these treatments. So nowadays we are keen of doing this sort of treatment in babies. And I think I am the first one to talk about now prevention of malocclusion in babies. So we are preparing the basis for that. And the courses, the intensive courses, if you want to go deeper in the knowledge, it's important to come here in Brazil because we have intensive courses. And yes, we have the recorded courses in English, and now we have I had to learn English. I'm sorry, my English is not perfect. I hope you can understand, but because of the need of English courses, I'm now with the English courses here in Brazil. The team, my transdisciplinary team, it's not, it's not a common language here in Brazil, but most of the team speak English, and you face an experience here with all the team, not only with me, but the whole team. Since pregnancy, you have the opportunity to capacitate in observing the ultrasound, observing the neonatal babies at UC's neonatal as well. We visit the hospital, we work in, and you have the opportunity to learn deeply about this knowledge. So this is the way. Of course, Cosmina, it's not a common, dentistry for babies is not common. It's not a regular course. Now in Brazil, for the specialization course in pediatric dentistry, we have a space for babies. And now we are open the space for prevention of malocclusion in babies as well. I teach in these special courses, special for post-graduation and specialization courses. See?
How do the gynecologists see you when you are going with an ultrasound and said, I saw something is wrong with this baby's mouth and face develop on this ultrasound? How are they reacting? Because I think it's very strange.
You see, Cosmina, since the age of 206, I'm talking about this because of this patient, Angelina. And everybody thought you were crazy, nothing to see. No, no, it's not a good thing to do. They think I was crazy. But Last week, I was in Mauritius Island in the Physician and Healthy Care Congress. Only physicians specialized in public health care, and they were interested in better prepare the echographists, the ultrasonographists to better observe these images. Because ultrasound is cheap, ultrasound is easy to perform, not invasive, and at least the World Health Organization recommend to do at least 3 exams during pregnancy. So most of the pregnant women at least go under 3 ultrasound. And there is a lot of information. So it's a very important diagnostic tool for diagnostic of um, oral and facial situations, you see. So we need to better capacitate these professionals to start observing these images. And here we can find a very interesting thing. We only see what we know. If we do not know, we do not see. So we have to better prepare the echography. I was in this special congress with the physicians talking about how to better prepare the echographies, to better observe these images, and how we can, improve the diagnostics for dentistry, and not only for dentistry, for the otorhinolaryngologist as well, because as I said, the fetus is learning how to breathe intrauterus. And sometimes we have, how do I say, the death, the birth death, because they don't know, they are not mature enough to breathe after birth. And they may forget to breathe and then have this problem. So, see, we start observing this maturity since pregnancy, for instance, because we are going to talk about a universe of diagnostics that can be done with the ultrasound. We can better prepare this baby after birth with a better transdisciplinary team.
So I can wait to see you in Timisoara. I can wait to listen to all of these things that you have introduced us today, and learn tips and tricks, because I don't think we will know everything in one day, but I think we will open our
Yes,
appetite.
unfortunately, it's only 8 hours.
Will open the appetite for knowing more and more, and make research about that, and even want to come to Brazil or to bring you here for 1 week to do this master course. And it will be a beginning of a new era in the pediatric dentistry, a complex point of view about the child, the development of the child, the mouth, the gums, the teeth, the everything, the breathing, sucking, everything. And we will find tips and tricks. At least we will have some tips and tricks to apply in our offices right after your master class. Uh, if you have something to add, I'm happy to listen. And I think everything was very clear, that we will have 8 hours to talk all of these things. Um, you will teach us about the exercises. You will teach us what parents should do at home with the children. That's important, to give homework to the parents. I think this is an important part, that, as you said, the parent must be the first one who accept the treatment, and to be to go all the way with us in some kind of treatments. And they will be involved in exercises and everything that will require. Uh, and that's it for me. An amazing pleasure to meet you and to discuss with you. If we
Yes.
have questions, please, from our doctors who is watching us, please, in chat, you can write if you have questions for Dr. Chedid, and I will ask. Okay, tell us about the exercise that you do with the babies, exactly, that you teach the parents to do.
Uh-huh. Yes. This one important thing I would like to say, Cosmina, uh, you cannot expect from 8 hours course to learn everything about how to manage, how to deal with the babies. The idea is to open your eyes, broaden your mind to the big universe of the prevention of malocclusion in babies. To manage babies need a well capacitation, a good capacitation. So everybody wants to know how to do the exercises. And of course, the idea is not that now you start doing the exercises or teaching the parents how to do the exercises. You will see how we manage this. We start relaxing the muscles. We always start with the relaxing exercises, relaxing the muscles, special muscles. I will show you in the seminar, and then they are according to the diagnostic, because I repeat, the most important thing is diagnostic. And according to diagnostic, we have specific exercises to be done. And first of all, before doing the exercises, we prepare the baby for the physiological functions, because these are the main important thing. Everything start going wrong, let us see like this, if one of the functions is not maturity enough or is not established properly. So after this diagnostic, we have specific exercises, digital compressions for protruded mandibula, retruded mandibula, maxilla atresia. Don't know how to say when we have a maxilla, a narrow
Yes.
maxilla, because sometimes as dysfunction, the learning how to swallow, how to breathe intrauterus is not properly matured, the tongue is lower, is in a lower position, and then the maxilla is not well anatomized as well. So we start the diagnostic first, and yes, I'll show you a lot of tools for diagnostic, and step by step, because we have a protocol, so we have a step by step from extraoral observation, intraoral observation, to make a good diagnostic. And then in the second part, I will show you the interventions, the proper interventions according to the age of the babies. And the exercises is one of them. And not only exercises to relax the muscles, but to start with digital compressions to stimulate the growing or the anatomy of the bones.
Perfect. So I invite all the doctors to go to our websites, www.smartpedodontics.com, Smart Pedodontics, and they will have all the information. I invite you all to come to our seminar with Dr. Chedid. The price can be paid only for the master class if you don't want to come to the conference, so it's individual. It's not, you don't have to go to all the conference, and I think you will have the opportunity to find interesting things, new things, and to apply them in your offices with your babies, patients right away. And to inform the parent, you will be a better informed doctor, and you will know better what to recommend, what to do for this kind of patients, small patients. Dr. Chedid, thank you so much again. One of our doctors, thank you for bringing this topic into perspective. And I think everybody will be very, very satisfied of all the information they will receive when they will come to our masterclass. So if there are no other questions, I thank you so much. And everybody can scan the code, which is on the screen, and find all the information, all the lecturer to our event that will be soon in 1 month. We are preparing. We are on the last things we are doing now, and we are very excited that we have such a conference where such speakers like you, Dr. Cassian, Dr. Paloma Perez, and all others are coming. Thank you so much, Dr. Kedid, and I can't wait to see you. Have a beautiful day. It's evening here,
Thank you.
but you still have all your
Yes,
day.
it's day here.
Thank
Good
you.
night for you. Thank you very much and see you soon.
Thank you so